update. Okay, can we go to the agenda, please? Next slide, thanks. So basically what we're going to do is talk about the learnings we've had from trying to implement the lower limb recommendations in, yeah, thank you, in the 7 first tranche implementation sites we've got working at present and are doing a sterling job out there, trying the best they can with the challenges in the NHS they are at present. So we'll pick up on that. We've got some case studies of some of the learnings, and Shiv will update us on that, and then we've got time for Q&A. So I'll hand over to Rachel, who's the Clinical Implementation Manager, who will take us through the presentation. Thanks, Rachel.
Thank you, Simon. Hi, everyone. My name's Rachel. I'm the Clinical Implementation Manager at the National Wound Care Strategy Programme. It's really nice to see so many of you on the call. I've noticed someone's having difficulty with sound in the chat, so I'm hoping that you can all hear me okay. So, most of you are well aware by now that in England we've got a really huge amount of people with lower limb wounds. And when we talk about lower limb wounds, what we mean as a programme is both leg and foot ulceration. And when it comes to leg ulceration, the vast majority of those are due to venous disease. And unfortunately, the issue we've got there is really delayed rates of healing and really high rates of recurrence. When it comes to foot ulceration, the problem's a little bit different. So there we have quite well-established pathways and services for people with foot ulceration and diabetes. As far as we can tell from the data that we have available, though, the number of people who have foot ulceration and do not have diabetes is at least equivalent to those who do. And the group without diabetes actually account for a higher number of amputations. So therefore, whilst the healthcare needs of those two groups are really similar, people without diabetes find it quite difficult to access the care that they need. The reason that we're in this position, and the main reason for the increasing burden of wound care, is unwarranted variation. So too few patients receive evidence-based care. So instead we have a tendency for an over-reliance on things like dressings and products, which often manage the symptoms of wounds really, really well, but unfortunately they don't treat the underlying disease process. Too often we've got wound care that's really poorly organised, which means there's really significant delays in people being able to access care from clinicians with the knowledge, skills and the time to be able to effectively diagnose and treat the underlying cause of the wound. So our system isn't really set up in a way that makes it easy for the patient or for the clinician. Finally, we've got a situation where there's very few organisations which have systems to support them to accurately capture clinical wound care data and information. So many of them are blind to the scale of their local problem. And of course, that data is really important to both informing and sustaining quality improvement. So we've set out to try where we can, the unnecessary variation in lower limb care, making better use of health and care resources and improving outcomes for patients. But equally, we really want to improve job satisfaction for our colleagues right across the system. So you'll recall that the first thing the programme did was to identify some evidence-based recommendations for care. And they set out clinically what good looks like, and they seek to build on and address gaps in the existing guidance. The main highlights for the foot are bringing the pathways for patients with foot ulceration and without diabetes in line with those for patients with diabetes. For leg ulcers, the recommendations suggest putting patients in some form of mild compression in the absence of red flags and ensuring that that patient has access to a holistic assessment within 14 days. And once that's happened, that they have onward referral to vascular diagnosis and treatment as necessary. So in the case of venous leg ulcers, that would be treatment being strong compression therapy, and vascular service may be able to offer potential venous interventions, just as one example. Alongside that document, we also developed a business case describing the case for change and quantifying the benefits of doing so. So the slide that you can see in front of you now are the changes that we set out and ultimately what we believe the framework is for improving lower limb care. And it's made up of 3 main elements, and those are people, process and technology. So with people, we knew that we needed to outline a standard for wound care skills and knowledge and provide some high quality education to a multi-professional audience. And that also we needed some resources for patients and carers in order to educate, empower and support self-management. in terms of process, we knew that not only did we need evidence-based recommendations for lower limb wounds, but we needed to recommend completely reorganising the way in which that care is delivered. And so we suggested that this be done via dedicated lower limb services. In other words, services that are staffed by clinicians with the right knowledge, skills and time. And finally, with technology, we need to support clinical care and quality improvement through effective data capture and reporting, and work towards having an agreed set of national metrics to inform and sustain that quality improvement. So with those clinical recommendations and the fundamental principles in place, we progressed as a programme to implementation phase. Many of you will know that writing recommendations is the relatively easy part, but when it comes to putting them into practice, that's where the fun begins. It becomes a real challenge. But the mantra that we've always had as a team is that if it was easy, then it would have already been done. So therefore, what we did is we recruited 7 first tranche implementation sites across England, and we've recruited them to implement the lower limb recommendations. And they're putting those recommendations and our other resources into practice. And they're helping us to test some of the assumptions that we made in that implementation business case that I mentioned earlier. So as a programme, we're observing specifically how they implement our recommendations and the resources and what approaches they take. And we're working together to try and understand what the enablers, challenges, barriers and the gaps are so that we can try and work together to resolve them. Because we all know that simply writing recommendations and saying that things need to be done differently, it doesn't necessarily lead to change. Tools on their own do not solve problems. It's the people working together that solve the problems. So since commencement of the sites in April 2021, our learning to date has been, perhaps unsurprisingly, that in practice, recommendations are both interpreted and then delivered differently. And that can lead to continued unwarranted variation despite really good intention. And I'm sure that's the case for many guidelines that are produced. And I think it's a symptom of the way in which our existing healthcare services are structured. We often work in silos. So research, local context, practitioner experience, stakeholder preferences and values, and the level of buy-in you have locally often influence the decisions that you make. So as a result, additional national work has begun to refine our lower limb recommendations and to shape what the recommended service delivery models are for implementing them. So we're moving very much from the what to the how. So in terms of what we've learned so far, we've learned that the FIMPs, in terms of people and education, they're taking a really blended approach to learning. So they're combining online and face-to-face delivery locally in their areas. And they've been doing that right across the workforce. So for all of those who come across people with wounds as part of their job role. And they've told us that the online learning resources that we've produced in conjunction with Health Education England are proving useful building blocks in order to complement local practical education sessions. And they're a good foundation prior to attending the taught sessions or further developing clinical skills in practice via experiential learning. And they've told us that the wound care core capability framework, which sets out, let me just show you that, which sets out the expected wound care knowledge and skills for all patient-facing practitioners in 3 levels or tiers, which you can see here in front of you, is a really useful tool in mapping the required and existing capabilities of the workforce. I'm just going to go back. So the challenge, however, is that there's been some variability in how the wound care core capability framework has been applied locally and also in approaches to experiential learning. Whilst the areas have reported they've found our resources really helpful, there is that continued struggle in practice to get the ring-fence time for education. So whether that be planning it or delivering it or attending it. So wound care is often seen as a low priority, and so local approval to get wound care education resources made essential can be really quite difficult. And so with that learning, and understanding. This has informed some additional national work for us to map the tiers of the core capability framework right along the lower limb clinical pathways, setting out what level and skill and knowledge is going to be required at each stage of providing lower limb care. We've also reflected that there's the need to further explore how to go about educating the workforce. So based on feedback we've received to date, we recognise that we need to review the draft lower limb curriculum that recently went out for consultation. So we're now working on aligning that much more tightly to the capabilities framework and expanding it across the wider workforce involved in lower limb care, and also developing some recommendations on that practical experiential learning. The good news is that with persistence, the importance of wound care education is being recognised. So some of our sites have now managed to get our online resources made essential or mandatory within their organisation. And my colleague Siobhan will be telling you a little bit more about that later and has an example case study which we can share with you. What we've learned in terms of revising pathways and processes is that despite a pandemic, large vacancies and immense pressure right across the system, our first tranche sites have managed to progress implementing the lower limb recommendations. But of course, it takes time and it's often done in stages. All of our first tranche sites have managed to either expand existing dedicated services or to reorganise their existing services to provide a dedicated service. And that's very much the case for leg wounds, but that process is taking a little bit longer for reorganising foot pathways. Where you do have those dedicated services, there is the protected time to deliver the appropriate care. So what we've seen is areas struggle a little bit, whereby they've tried to implement or incorporate the recommendations into the existing day-to-day practice of a service, rather than having that separate dedicated service. So, for example, incorporating assessments for leg ulcers in community or district nursing services, rather than having a separate service or dedicated roles within that service to deliver that element of care. We know that if we get the right people to the right place quickly, practitioners in that setting have the right knowledge, skills and time, then we do get better outcomes. And we also know that having specialist clinical oversight and leadership of a dedicated lower limb service is proving to be quite pivotal in order to ensure the right level of support and ensure that quality care is maintained. And that's particularly important if the dedicated service isn't a specialist service or doesn't sit under a specialist service. Of course, the local way and circumstance have shaped how FIMPs have approached implementing the recommendations, which is a challenge. So historical commissioning arrangements might mean some negotiation is needed with all the right stakeholders in the room at the table, because the way in which services are currently set up, we often haven't thought about the population. So we might have just set up a service for the ambulatory population, which is brilliant. But what about the homebound population and what about inpatients? We might have an area of good practice in one part of the city, but not the remainder. So we really need to improve on working as a system. We're also aware that there's been some issues in relation to onward referrals to our vascular colleagues, from who to refer to acceptance of those referrals, etc. So ultimately, our vision is for the delivery of care via dedicated lower limb services that span wherever the patient is, so ambulatory, homebound and inpatients. And we've been working with the FIMPs to try and get them to adopt that approach where it's possible. And we are now seeing progress with that. So, for example, Livewell Southwest originally had an ambulatory clinic model for people that could get to a clinic, but they've recently managed to secure funding to pilot a clinician from the service to do the homebound population. And in Wye Valley, they originally started with us with a homebound service, but they've now extended and offer clinic-based service too. So this is all a work in progress, but you'll see here that we're starting to build on our recommendations on the service delivery models, or how dedicated lower limb services should be delivered, allowing, of course, for some local variation. And we've also started to build, based on our observations and learnings, recommendations on the appropriate amount of time to care across the pathways, because we really want to support practitioners in practice by recommending sufficient time to allow good quality care. And we've also been working on improving timely and appropriate referrals to vascular services. So we've developed some example referral forms for peripheral arterial disease and also venous disease. Based on the feedback we've received, these are having some additional tweaks and they'll be back on our website shortly. And again, we've seen close working with our vascular services and FIMPs to agree local pathways and processes, and they have managed to overcome those challenges in practice. When it comes to data, digital and information, obviously it's really important to document that care has been planned and delivered, and to do that effectively in order to support continuity of care. The only way really that you can do that is digitally, so having really good templates and solutions to make the clinical pathways work. Ideally, we think that's best done with a wound management digital system, and we've got some examples of those on our website if you haven't already seen those. We know that the quality of data, if you get it at the moment, is quite poor, particularly for community services. But we need to use data to improve data. And when you get data, it often raises more questions than it does answers. But again, that's really good because it prompts us to go dig a little deeper and improve the quality of that information that we're receiving. We know that improving data capture and quality and effective information sharing between services is key to improving care. Because if we can't measure what we're doing, we can't see where there's unwarranted variation and help and support clinical practice and delivery. However, there's no recognised standard at the moment for a generic information record that can support the delivery of wound care, recording wound care data and information in the same way across services. So we all do it a little bit differently. Of course, we also continue to have that problem with our various systems talking to one another, including with wound management digital systems. So gathering data to demonstrate quality improvement and assist the sustainability of services remains a real challenge. And it's really hindered by your level of digital maturity locally on your ability to be able to track data. And so we've developed recommendations on what we believe good looks like for wound management digital systems and the use of digital images. We're also working with the professional records standard body to try and produce information standards to support the adoption of best practice in wound care and documentation, and that spans assessment, management, maintenance and prevention. And we've also developed some clinical metrics addressing key points of lower limb care in order to try and standardise how we collect data for wound care. And we're working with the first tranche sites to understand their ability to meet those and understand the impact. We're also working on a dashboard with the first tranche sites of core metrics so that you can visualise data and information for staff and close the feedback loop. And we're really having to take a deep dive now into that data that the first tranche sites are submitting to us in order to try and understand how it's being gathered, what data is being used and what population that it covers. Despite the challenge, the early results from the 7 sites are supporting the predictions that we made in the implementation case, suggesting that this absolutely can be done. As the benefits of improving wound care are becoming more obvious through work with our first tranche sites, it's starting to have quite a high profile with other health and care organisations and also healthcare policymakers. And so for us, that creates a really great opportunity as a national programme for the first tranche sites and wider stakeholders to collectively tackle the challenges together and make a difference. And we haven't quite cracked it yet, but that's okay. By understanding what helps and hinders in practice, we can take steps to try and address so that the changes we aspire to achieve are much more achievable, but also sustainable, because this is a system issue. It's not merely a clinician one. And so our plans are to continue to work with our sites to observe, learn and enhance our strategy. The Academic Health Science Network are also providing implementation and change management support to some additional sites to implement the recommendations. The learning from all of those sites collectively is being used to enhance our resources, and we're now at the stage where we are going to be developing some best practice bundles. So these are going to be set separate documents now for the leg and for the foot, and they'll incorporate the clinical recommendations and interventions, but also in their implementation advice and process and outcome indicators. Alongside that, we will also be producing some supporting resources to assist local implementation. As we move into the new landscape of integrated care systems, we're really hopeful that that's going to support our vision of delivering wound care services and solutions that move much more seamlessly between acute, primary and community care providers. Working more collaboratively to ensure that patients get the right care at the right time from the right service is not only going to improve wound care and outcomes, but support practitioners to deliver high quality care, ensure better use of resources and provide improved job satisfaction. Thank you very much. I believe I'm now going to hand over the talking baton to my colleague, Siobhan.
Thanks, Rachel. To you, Shiv.
Thanks, Rachel. I'm just going to go ahead and share my screen. Okay, so I can just see you, Simon. So if you just give us a wave if it's okay and you can hear me all right. Lovely. Okay, thank you. So I'm Siobhan. Some of you may know me. I'm a tissue viability nurse by background. I've just joined the programme to help build with some of the implementation case studies, just looking at those tranche FIMP sites and capturing some of the work that they've been doing. It's been absolutely awe-inspiring to be part of the programme and learn of all the amazing work that's been going on. Coming straight from clinical practice myself, I know what it's like out there. And so I thought it was really, really important that we capture this, share this, but also it's going to help inform future sites. So if you're considering taking any of the recommendations forward, hopefully there'll be something here that you'll be able to take away and have a look at or share with your colleagues. So we're looking first at the first published case studies. There'll be 7 in all, and the first 3 are available on the Futures NHS Case Study Hub. So this is initially where they're going to be shared. If any of you are within the NHS and haven't joined the Future Case Study Hub, it's a bit of a marmite at first. It's a bit of a love and hate, but actually when you join it, there's quite a lot of platforms on there, which is enables case study sharing. So it's not just for us. There's lots of different case studies on there, but this is initially where you'll find our case studies, which we've drafted with our FIMP sites. The case studies will be in line with the National Wound Care Strategy, Process, Technology and People, and they'll come under the banner of that and includes looking at some of the outcomes around the IHI, so the Institute of Health Improvement quadruple aims. So looking at the better patient experience, better outcomes, better health outcomes, improved clinician experience and lower cost. And so far, most of them kind of cover the majority of that rather than just the one. So I've popped the link on there where you can go onto the Future Case Study Hub and have a look at those. And I'm going to give you a very brief overview of the case studies. I should mention, if you're not on the Futures Case Study Hub, they will be shared wider. It's kind of under the next steps, looking at the website and other potential ways of sharing this information on a wider platform. So just keep an eye on the National Wound Care newsletter and the website, and that information will come out in due course. So the case studies that have recently been published, we've got Mid and South Essex Community Collaboration, or Provide, who, as Rachel alluded to, have managed to implement their wound care knowledge and skills workforce training as mandatory on their online platform. Any of us that have worked know in trying to get wound care on the agenda as mandatory, it's incredibly difficult to sort of jostle in there and try and get that out there. But it is there now. It's in line with the Health Education England platform, the ELF training modules, which are very accessible. They're very visual friendly, and they're available for non-registered and registered staff. It's a really good case study to look at how the fantastic TVN Andrea and the leads in in Mid and South Essex managed to get that out there, including a business case, which they've happily shared. We're looking at hopefully sharing and adding to the case study as well, so you can look at the nuts and bolts of how it got there. The interesting outcome for this one, which was an unexpected outcome, which I'm sure they won't mind me sharing because it's within the case study, is actually the AHPs are really accessing this as well. So it's got the lower limb work on there, but it's also got things like pressure ulcers, which OTs and physios can access as well. So service leads can actually choose which subjects they'd like to have shared within their team. And of course, that can be audited and checked as well. So that's that case study, and it's a fantastic bit of work. Manchester's is available to access, and Manchester worked on the co-design of their leg ulcer service, but really bringing in the patient and public survey aspect into it as well. So they conducted a patient survey which really kind of led to their co-design of their leg ulcer service. So really bringing the patient voice into it. And again, it was a very widely scoped bit of work. That the survey itself, the design, has also been shared within the case study, and there were some affiliations with the local university in the design of that as well. So it's a really good one to have a look at. And then Wye Valley, this may be a bit of a controversial one at first because it does talk about reallocating budgets where there's unfulfilled vacancies. I come from a long community background, so I know what it's like at the moment for the district nurses, and there is a lot of unfulfilled vacancies, and there is a lot of burden on wound care, as we know from publication and from guests' work. And what Wye Valley did is really explore those vacancies and see if they could reallocate any of that funding to actually create some leg ulcer nurse specialist roles within the community setting, which they did. And the outcome of that really was to reduce the burden on the district nurses, but also to take some of that role in making sure that people get their first assessments initially in clinic and then for the housebound population. So there was lots of capturing hearts and minds with that one in changing that way of practice. But again, there's some outcomes and some interesting early data that's coming from that as well in terms of better health outcomes. So have a look at that one if you can. They're all good, but it's a really good one. So that's the 3 that are published, and the 4 which are watch this space and are about to be published are coming soon. We have Hull, or the City Health Partnership, based in Hull, and this is quite a biggie. It's really the build up to the first assessment clinic. So anybody starting from scratch, it's a really good one to look at. And it also incorporates the first referral pathway. So they created some new referral pathways, but they also updated their pathways, both on leg and foot. And that led to their first assessment clinics. So you can imagine what a big bit of work that is. So that's there to look at as well. That's going to be coming out soon. Next, we'll be moving over to Kent, who've implemented a supported shared care wound management criteria and patient information resource. And this is, again, very community focused bit of work. And it was taken initially from the National Wound Care Strategy. We've got a shared care plan on our website. It's going to be reviewed because, as ever, the programme kind of evolves and adapts based on your feedback. So there will be some tweaks and changes to it. But what it offers is an assessment criteria for supported shared care with your patient and or carer, and looking at and how we might be able to support that in a more formalised, standardised approach. So Kent really took up the baton to that idea, and they incorporated some patient and staff surveys on the kind of perception of supported self-care, but also on the tool itself, and incorporated some patient information resources as part of that work plan as well. So that's Kent. And Live Well, this is the only one we picked up so far under the technology banner. There's so much with wound data and wound metrics. It's still a tiny bit above my head, but there's some amazing data people leading on this work. And this will be looking at the implementing a wound management digital system. And this is really about not having the answers at this stage, but about how to make the case for a change, how to make the case for looking at wound management data systems, not in just capturing wound photography, but actually using the data to help structure our service and collect key metrics data on our wounds. So that will be coming out. And lastly, Central and Northwest London, looking at the confidence to compress, which again, it's following the immediate and necessary care. There has been some reservations, some concerns about putting reduced compression on patients once the red flags have been assessed. And so this is really about the team here have been working with acutes. They've been working with their long-term care facilities about how they can present pathways to support reduced compression in a sort of non-standardised area where district nurses may not go in, for example, so nursing homes. So that will be a really exciting bit of work that's going to be coming out as well. So they're the case studies that are coming out soon. And as I say, keep your eye on the National Wound Care Strategy website, because those aren't on NHS Futures. They'll be coming out in various formats over the next few months, so keep in contact. I think that's me. I'm going to stop sharing now and hand back to Simon. Thank you.
Okay. Thanks so much, Shiv, and thanks very much, Rachel, for taking us through that. There are some, we asked for questions to be put in the chat box. I made a note of those I've gone through, so I'll pick any up as we go through. The first one was raised around which setting of care does the time to care apply, please? Is it for single limb or bilateral? Rachel, can I hand that one to you?
Yeah, of course you can. It's a really good question. So at the moment, we're just at the stage where we've been observing. We had an idea of what we thought would be required at each stage of the pathway in terms of the time frame, but out of interest, we asked each of the 7 sites what appointment times they were giving for those elements. So most of them responded, and they responded mainly for the leg rather than the foot. So we're still doing the work with our podiatry colleagues. So at the minute, it's a really good question. What we've observed is that they're allowing that type of time for bilateral or unilateral. It doesn't matter. Those figures, the minutes that you saw on that slide, are not finalised. That's just us still testing out as part of our learning programme the feedback that we're getting from our sites, trying to implement them in practice. But I know as a clinician, I'm really keen that we do support people to have the right time to do their job effectively. So if we're saying that a dedicated service needs to be set up, that's one part, but the other part is still allowing those clinicians the sufficient time to care. So it's anything that we publish, or so for example, our best practice bundles, if we incorporate that advice in there, obviously it goes out to consultation. So we'd welcome any feedback on that.
Okay, thanks, Rachel. The next question, which I picked up, which I know is in the chat, but I'll just repeat the thing, was have the digital software companies been updated on the National Wound Care Strategy webpage? Basically, we've had to withdraw the register at the moment as we've had feedback it was being interpreted as an NHS validator endorsed catalogue, which clearly we can't as a national programme do anyway, but it's of course got to be led by procurement teams and procurement rules. So it isn't that. It's an horizon scan only that we published before. So we're working to position the register correctly, and we'll update the web page soon. So hopefully that answers that question. So thanks for that. And one question was maybe controversial. Right, which of the clinical services and specialities have a generic tool? Why is this needed? Suggests we all know what, why, and when is it needed, and wouldn't our efforts be better deployed to address differences in access to performance systems and data at ICB and provider organisation level? I think, Mike, that's a digital question. Are you able to respond to that? Mike leads our DDI work. Mike,
Francis may need to take Mike off mute.
Right. Can you unplug Mike, as it were?
Unplug Mike.
I can't actually see him on the list.
He's on the call, yeah, he's answering the chat, so I know Mike's around. But...
Yeah.
Have you found him, Francis?
Yeah, just looking for his name. I think it's in alphabetical order, so hopefully it won't take too long. There he is.
Is that first name or surname?
Oh, surname, yeah. Yeah.
Where we start. Yeah.
Hi, can you hear me okay?
We can.
Mike, thanks, yeah.
Hi, Mike.
Yeah, thank you. I think in order to answer the question, I think I might need to understand when we talk about a national generic tool, it would be helpful if Helen might maybe just give me a bit more to go on. Is this about a national information standard, or is this about something else that's defined as a tool?
Helen, yeah, you there, Helen? You can we unmute it? Or Helen, can you put it in the chat? Because I think you're muted. I think unless Francis can unmute you.
I'm going to, whilst Helen is typing in the chat, I suspect it is to do with the PRSB work, Mike. If you want to elaborate on,
okay,
on that
I can
do.
Work. Yeah, I can do. I mean,
it is the PRSB work, National Information Standard. Yeah, thanks.
So there are other clinical services and specialties which do have information standards defined for them. So, for example, diabetes has got an information standard, and other care settings have standards for them as well. So there's a shared care standard. The reason why we think we need to define one nationally is we want to make sure that people are capturing the same information to support the care of a patient along the pathway. So if we don't do that nationally, it'll break down at the edges of certain healthcare systems. So if care's being delivered in one organisation and then passed to another, that information standard is designed to try and help the pathway of the patient, or the patient as they move across all the health settings that they get wound care provided to them in. So that's why we think we need to define one nationally. The upside of that is we then think that if we can get that information standardized, it can then flow into the national data sets that we all use to compare services and to manage services. So things like the hospital episode statistics return, and also the community services data set return. So I don't think it's a controversial question. I think it's a really valid question, and it helps us think about it. But I think we're confident that we need to start to define data to define the sorts of information we'd like to be captured across the country, and do that once through this information standard. Does that help, Helen? I'm happy to have another conversation with you if that would help.
Hopefully that does help, Helen. Clarifies why we're doing what we're doing. One question that has come up is there a standardized first assessment pro forma? Rachel, do you want to
repeat the question for me? Sorry.
Is there a standardized first assessment pro forma?
Oh, good question. As in what you complete at that very first assessment. So it's contained within the recommendations. So the recommendations, originally, you will recall that we had the lower limb recommendations, which had a section for the foot and section for leg wounds. So what we're doing now is, you may have seen that we've separated those now. So the recommendations for the foot have just gone out for consultation, and I think they closed on the 20th or 21st of January. So in there, we've broken it down more clearly. You'll see they look quite different to what they did before. But within that first section of assessment, it goes through exactly what should happen at that appointment time, that initial assessment. So it includes things like your vascular assessment, a wound assessment based on the minimum data set, etc., etc. So I hope that answers your question, but please feel free to type in the chat if I haven't answered that correctly.
Okay, thanks, Rachel. There's been various questions about the case studies, and both Rachel and Shiv have posted the website for where they are located. So if you're struggling, click on the link. You'll have to log in, and it's an NHS only staff who can do that. I know that, but just to access and look at them. So that's on the website, the Futures website platform. There are no other questions in the chat, so we've got time. If people want to ask any more questions, please put them in. We'll give a couple of minutes for you to do that. Is there anything else, team, we need to just cover with where we are now?
Not that I can think of off the top of my head. I guess, Siobhan, you've already covered, haven't you, that those case studies are just on the Futures Hub for now. But do you want to expand on the work going on and the conversations you've had in terms of how they may be adapted?
Sure. So the case studies, when you first look at them, guys, they are quite big. They really are not like mini business cases. Sorry, someone will probably tell me off for that. They're not business cases, but they are. They're there to inform future business cases. So they have to be robust, and we have to show the impacts as what we can with the data that's being shared with us. But we're really aware that if you're in a coffee queue and you've got a 10-minute break and you see something, you think, actually, that's something I really want to do in my workplace, you might not have time to look at an 8, 9, 10 page case study. So there's some ongoing conversations with our comms team and a fantastic project officer who's joined us in looking at building up some summaries and vignettes. So essentially some smaller ways of sharing these case studies that are in a bit more of a summary format, so that we're not alienating clinicians, non-registered staff, AHPs, other people that are patients themselves that may want to pick that up and help inspire their work in what is a very difficult circumstance at the moment, very busy practice. So yeah, so watch this space, that they'll be coming up, but we're very aware when you look at them, don't worry, that's not it. There is going to be different formats that are coming out as well that will make them more accessible.
Thanks, Shiv. Rachel, there's a question that's asked about the recommendation. Will they change again? Let me just go back in. So when the recommendation comes out, will it change again? As I assume the leg also recommended.
Yeah, it's a good question, Sally. So as I said, the leg recommendations have just been out to consultation, our colleague Krishna, who is the clinical lead for the lower limb workstream and a podiatrist by background, is currently reviewing the recommendations for the foot. So they are being expanded, so there's more detail in it. So yes, they are going to change, but it will go through a process of consultation like the leg ulcer one has done. So I can't remember the dates off the top of my head, if I'm honest with you, but they are in the process of being written now. And as I said, both those recommendations are going to be the foundation of these best practice bundles that we're developing. So the recommendations will be one part, but there's also the implementation advice and the indicators and all the other resources that will go alongside that to support implementation in practice. So the first stage is for us to tweak the recommendations based on what we've learned and what the first tranche sites have told us and what you guys have told us from our consultation processes. So there's still some tweaks to come, and that's part of us being a learning programme.
Thanks, Rachel. Another question that's come up around baseline data. I had a question about baseline data. How did the FIMPs gather good baseline data so they could measure against non-elective admissions, wound care spend, infection rates, and use of antimicrobials? We are finding delivery starts as data gathering improves, so baseline data isn't reliable.
Does Mike want? Is Mike still on the? Is
I am, yeah. I can start, Rach, if you like, and then you can maybe chip in terms of what that means. I mean, fundamentally, it's related, I think, to the point around the information standard. We know that there is often an absence of wound care data being collected to support wound care services, and that wound data that is being collected often isn't of a high quality, and so it didn't feel right to ask FIMPs to do a baseline data collection, because it would require them to go back and do an awful lot of audit work, which we don't really think is useful. We want to make sure that the data that we're starting to collect is routine and operationally useful. So we didn't want to burden the FIMPs with a sort of retrospective audit if we knew that audit was going to contain either big gaps in the data or data that didn't necessarily mean that we could interpret it. So we didn't ask them to do any baseline data. What we've been doing with them since about the big midway through last year is starting to give them a set of clinical metrics that they could start to understand how they might collect those metrics, and then start to do the improvements locally to make sure they've got the systems and processes in place to collect that good quality data that we need to demonstrate our impact. And that's a process that's still ongoing. I think Rachel referred to the deep dives that we're doing with the FIMPs at the moment to really start to see if we can interpret the data they're now starting to provide through, now that we've got increased confidence in the definitions that they're using and in the way that they're collecting that data. Is there anything you want to add to that, Rachel?
No, I think that was very comprehensive.
Okay. Thanks very much. Nothing to add, Rachel?
No, I don't think so. I mean, just from a personal perspective in practice, you kind of do. So, for example, Y Valley, Shiv will know, who having done the case study recently for Y Valley, they did like a baseline, manual audit, and a lot of us are used to doing that in practice as part of our services, aren't we? But as Mike says, we're aware of the issues with that, and there's something about spending your time wisely and effectively, and is that doing a manual audit? Probably not, but some FIMPs did start with some form of baseline data, but a lot of it was quite historic. So I think Y Valley did theirs a couple of years before they joined us as a FIMP, and they didn't redo it because we kind of knew that the wound care was not ideal, so there didn't seem a point in repeating it.
Thanks. We've had one question about do we have any feedback from FIMPs in regards to staff satisfaction scores? I noticed the improvements in patient satisfaction, but as a TES, we would like also to capture all staff experience. Didn't want to reinvent the wheel if already done. Rachel, do you want to?
Yeah, it's a very Shiv and Mike may want to add to this too. So yes, it's something that I feel very passionate about as a clinician, obviously, as many of you on the call do. So yes, it is something we need to look at. I guess at the moment we have issues with getting any kind of data at all. But what Shiv has managed to do is kind of get nice qualitative qualitative data in terms of quotes and things whilst working on the case studies. Shiv, I don't know if you want to elaborate.
Yeah, I agree with Rachel. We really have to capture that, and patient satisfaction is really important. But without our staff, we can't get them to patients. And so staff outcomes is actually one of the IHI outcomes we look at, and it's really difficult to try and capture that because there isn't a standardized survey. So what each of FIMP have done, they've invented their own staff survey, and that they'll be embedded within, I think Kent and Livewell have done it as part of their work, but all case studies will have some qualitative feedback from registered, non-registered and AHPs as part of their work. So it's kind of that real world feedback there and then as they've been implementing whatever part of the project they have. So that's inbuilt in within the case studies, but nothing you can take and use. I think it might give you some ideas about how you might want to construct your own staff survey, but there won't be one per se that you can take away and use within your own practice. But talk to each other, because I'm sure they wouldn't mind sharing them with you.
Mike?
Yeah, and just to add on to that, I agree with everything that's been said. It's an essential part, isn't it, and part of the quadruple aim. So we absolutely do need to be able to demonstrate something against it. We've started a process now working with the FIMPs to collect their methods for assessing both patient and staff feedback. That's an exercise we've just started, and we'll be sharing the outputs of that through the Transforming Wound Care program as we start to get that. We'll be sharing it through our relationship with the Transforming Wound Care program. So I'd like to think that would then start to cascade that learning through to any test sites that are trying to implement it. I do appreciate there's a bit of a lag there, but we're a small team and we've started with the other domains of the quadruple aim, so our clinical impact and our workforce productivity impact, and the experience bit is one we haven't lost, but it's one we're picking up this year.
Thanks, Mike. And it's worth saying that community services never had the investment in digital collection, data collection that the acute hospitals have in many. So we are trying to go against that battle already, trying to get the data out of it. But there's one good comment around any evidence being collected on impact on nursing time. It's a metrics we are developing. Mike, Rachel, do you want to feedback on that? And we know qualitative people have said, releasing capacity here. As you say, without the data proving it. So Mike, do you want to come in on what we're doing on the metrics around that or not?
Yeah, absolutely. And thank you, Alison, for the question. So
great question, Alison.
Yeah,
so key, isn't it?
And as you said, Simon, it's a fundamental part of the implementation case, isn't it, to release that time? So the short answer is yes, but no outcomes that we can interpret as yet. So we've got two pieces of work going on here. We are trying to make sure, again, that we're collecting the right data at source. So again, we're not asking the FIMPs or anybody else to implement this to collect additional workforce data. We're really trying to reduce the burden of data collection on people that are implementing the recommendations. So what we're trying to do is we've got a set of metrics that we think demonstrate the impact of workforce productivity by implementing the recommendations. We're now working with the FIMPs to see if we can improve how that data is being collected and how it flows through up into the national data return CSDS, or the clinical services data set. We're really trying to see if we can use those national returns so that you can then demonstrate back to your commissioners or whoever else is interested what that workforce productivity gain has been. So it's in our work plan for this year, and we're working with the FIMPs to try and establish that. But there's no data I can share with you right now.
Great question, Alison, as we said, and we'd love to have that data to show the increased capacity. Certainly, qualitative, we get it definitely. Sort out one nice comment. So thanks, Helen. Good. Thank you. Explicit link between the generic tool that we're trying and the purpose for monitoring quality outcomes may be worth making for clinicians and trust boards. If we cannot access performance teams, as wound care is not the essential contractual obligation for providers, how can NSA do to influence this? So I think in terms of the implementation pack we're going to develop as part of the bundle, those sort of things we'll take that comment and stitch it in where we can. We're trying to find as many hooks as we can for ICBs as they move towards integration more and more, and providers to be able to use for cases like this and make the case for change. It's a challenge, let's be honest. NHS England is going through massive change at present, and ICBs are maturing, some more than others, and providers are battling the elective backlog. So it's where priorities lie, but we're trying to develop as many hooks as we can to get people wanting to take this up and support it. We do have 5 more questions, 5 more minutes for any questions. And if we have no more, then we can finish early and get some time back and get a cup of tea before your next meeting or your next clinic, whatever you're doing. But if not, so we're going to post this on the National Wound Care website, the seminar, and the questions also we've answered, so there isn't any need, I don't think, to put anything else out on those, unless any more questions come in now we can't answer. Hopefully everyone's got what they wanted from today, or as much as they could get from today. So given no more questions come in, shall we close this down for the day, Francis? We're happy to do that.
Okay.
So can I just say a big thanks for joining the seminar. Also a big thanks to Rachel and Shiv who did the presentations, and Francis for sorting us out in the background, and Mike who's helped on the data digital information stuff. So thank you very much, everyone. Wish you well in your journeys, pushing wound care up that agenda, which we desperately need to improve outcomes for patients. And have a good afternoon, everyone. So take care. Thanks very much. Bye.
Yeah, thanks everyone. Take care.
Bye.